Hello, everybody. Today we're going to talk about sepsis and taking care of our patients that are suffering from sepsis. Upon completion of the class, you're going to be able to identify the signs and symptoms of early and late sepsis. We'll be able to define each stage of sepsis based on the clinical presentation of your patient and define at least 2 nursing interventions and 2 medical interventions for patients with sepsis. According to the CDC website, taken in October 2020, it was estimated that approximately 270,000 patients die a year from sepsis in the United States. Sepsis takes more lives than breast cancer, opioids, and prostate cancer combined. The actual incidence has been difficult to assess due to previous inconsistencies with definitions, and as a result, a broad range of instances and mortalities have been reported. So nonetheless, sepsis is often a fatal disease with mortality ranging from 28 to 50%, with an overall hospital mortality rate approaching 30%. Sepsis is a infection along with organ dysfunction that can rapidly progress to septic shock, which is persistent tissue hypoxia with vasopressin use within 24 hours. Mortality for sepsis and septic shock are higher, ranging from 28 to 52% and 82% respectively. In addition, the economic impact can be quite substantial. They range anywhere from $24 billion per year. For this reason, sepsis has been the focus of much attention in quality initiatives. Society of Critical Care Medicine and European Society of Critical Care created a Surviving Sepsis campaign in 2002 with the goal to decrease sepsis by 25% over 5 years. Keystone and MHA in 2003 and IHA, Institute of Health Improvement Sepsis Bundles, to name just a few. A 25% reduction in mortality from sepsis could save the lives of 50,000 people in the United States. Absent a cure for infectious disease, few other interventions could have such a dramatic impact. According to the CDC in October 2020, this is the estimated hospitalizations for patients suffering from sepsis. They were more severely ill than patients hospitalized with any other diagnosis. In here, you'll see that patients suffering from sepsis from male versus female is quite the same, and it really ranges from any age group here. Please note that those hospitalized for sepsis had an average length of stay that was 75% longer than any of those diagnoses in the hospital. Those under age 65 hospitalized for sepsis had an average length of stay that was more than double that of any other hospitalization diagnosis. And those age 65 and over hospitalized septicemia or sepsis had an average length of stay that was 43% higher than any other patient.
As critically ill patients fight infectious insults, there is often an excessive response that results in the syndrome of severe sepsis. Clinically, you may see increases in temperature, heart rate, respiratory rate, and abnormalities of white blood cell count or differential. As the disease progresses, blood pressure may drop with organ hypoperfusion, and organ systems such as the respiratory, cardiovascular, hepatic, central nervous, and renal system may fail. Traditionally, this excessive response has been associated with the disruption of homeostasis through an uncontrolled cascade of inflammation, coagulation, and impaired fibrinolysis. Deeper examination shows that the microcirculation is the key focus of sepsis injury. The sepsis cascade begins with the activation of the capillary endothelium in response to an infectious agent or toxin. This endothelial damage exacerbates the inflammatory process, resulting in neutrophil activation and expression of adhesion molecules. Neutrophils begin to roll in the capillary and adhere to the endothelium. The increased endothelial permeability leads to a loss of vascular integrity and consequent microvascular leakage. In the lungs, this interstitial and alveolar edema leads to acute lung injury and acute respiratory distress syndrome. Concomitantly, coagulopathy and impaired fibrinolysis prevent red blood cells from delivering oxygen to the organs, resulting in inadequate perfusion and global tissue hypoxia. The amplification of the coagulation pathway results in large amounts of thrombin formation, which converts fibrinogen to fibrin. Fibrin threads with activated platelets form a clump at the site of endothelial activation. Reduced arterial vascular tone, diminished venous return, and the release of myocardial depressant factors lead to hypotension. This is a scan of the capillary circulation in a normal patient. Note the rapid blood flow and numerous capillary loops. Now you see a patient in septic shock despite restoration of normal hemodynamic parameters through treatment with fluids and vasopressors. Note the poor blood flow and capillary loops with intermittent or occluded flow. The depressed myocardial function, widespread tissue ischemia, and multiple organ dysfunction often lead to patient death.
In this video, three things are happening. There's increased inflammation, increased coagulopathy, and decreased fibrinolysis that leads to that organ failure. So some of the challenges in identifying patients who are septic is the signs and symptoms can be masked by other illnesses or comorbidities. There's not a gold standard test or diagnostic test that indicate patients septic. You really have to use your clinical judgment. And presentation may differ depending on the patient situation. The Surviving Sepsis campaign was an international effort organized by physicians that developed and promoted widespread adoption of practice improvement programs grounded in evidence-based guidelines. The goal was to improve diagnosis and treatment of sepsis. Including among the guidelines were septic screening for high-risk patients, taking bacterial cultures soon after the patient arrived at the hospital, starting patients on broad-spectrum intravenous antibiotics before the results of the cultures were obtained, identifying the source of infection and taking steps to control it, such as if the patient had an abscess, to drain the abscess. If they had infected lines, remove the lines. And so they wanted to take control of the infection by also administering IV fluids to correct the loss of blood or fluid loss and to maintain glycemic control. These and similar guidelines have been tested by a number of hospitals and have shown potential for decreasing hospital mortality due to sepsis. Tracking data included in this report over time will enable policymakers and healthcare professionals to assess the effects and efforts to decrease death rates. Some other sources of infection, the number one source of infection is lung infection. Example would be pneumonia, which we see occurring more in the winter months in Michigan. Urinary tract infections is the second runner-up. Gut infections and skin infections are also included in some of the common infections that lead to sepsis. Other infections are burns, fractures, infected lines that we see in the hospital. Some classic signs and symptoms that would indicate a patient suffering from sepsis would be clammy skin or sweaty skin, confusion, disorientation, shortness of breath, arrhythmias, tachycardia, extreme pain and discomfort, and it's shivering or fever or very cold. Some of those are classic indicators of the patient suffering from an infection. So sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. Sepsis has a mortality rate of 10% or higher mortality rate than that of a heart attack, stroke, or trauma. Life-threatening organ dysfunction is consistent with the view that cellular defects underline physiological and biochemical abnormalities within specific organ systems. Sepsis could warrant a greater level of monitoring and intervention, including possible admission to critical care, depending on if they're going down the sepsis continuum. So this is a SIRS criteria. It's systematic inflammatory response syndrome. And this is what we would do every shift to monitor for sepsis in our patients in the inpatient setting. We look at certain criterias, and these criterias doesn't really mean that the patient is septic, but it is a portion of organ dysfunction. So if the temp is high, above 100.9, or lower, below 96.8, heart rate 90, above 90, white blood cell count above 12,000 or less than 4,000, white blood cell count bands above 10%, and respiratory rate above 20. So this is just an indicator of maybe some organ dysfunction. And if the patient has two or more SIRS criteria, and also looking at the screening for organ dysfunction, at least one of the following organ failure criteria, Epic will shoot an alert in the charting system that will indicate for the nursing staff that the patient may be suffering from sepsis. Some of the things that are involved in the screening for organ dysfunction is they look at vital signs. They will look at certain lab values like creatinine, lactic acid, platelets, bilirubin, INR. So all this is done behind the scenes in the computer. And then if they meet this criteria, you will see an alert system. And we'll show you that in a few more slides. So this is septic shock. It's a life-threatening organ condition caused by a widespread infection associated with a higher risk of mortality. It's defined as a refractory hypotension despite adequate fluid resuscitation, requiring vasoactive medications to maintain a mean arterial pressure of 65 and above, and lactic above 2. The task force that we were mentioning before recognized clinical criteria for septic shock, were developed with a hypotension and hyperlacticemia rather than either alone, because of the combination encompasses both cellular dysfunction and cardiovascular compromise and is associated with a significantly higher risk of mortality. So in this, you would have to have an infection, organ dysfunction that leads to sepsis, that meet two of these clinical criterias, which is persistent hypotension requiring vasopressors to maintain a mean arterial pressure of 65 or above, and lactic acid 2 above despite adequate fluid volume resuscitation. So this patient would need fluid volume resuscitation or fluid boluses. And if they can't achieve adequate hyperperfusion or perfusion, then they may need vasopressors, which would indicate their septic shock. As we go down the continuum of sepsis, it could lead to multiple organ dysfunction. MODS is 2 or more organs failing. So the patient would pretty much be in the ICU, and every organ that dysfunctions correlates with a mortality of approximately 20% with each organ. Life-threatening organ dysfunction is consistent with the view of that cellular defects underlying physiological and biochemical abnormalities within the specific organ system. MODS is a precursor to death. increasing the number of organ dysfunction correlates with increased mortality of 20%. Sepsis screening tool has been proven to quickly identify sepsis early and avoid preventable deterioration. They want to screen every patient, every shift, every day. So this is what we see in the inpatient side. This is when the patient meets the SEERS criteria and the SOFA criteria, that this alert will pop up on the screen before you enter the patient's chart. And then it has to be acknowledged. Either we could uh, order an order set, or possibly acknowledge some reasons why we're not ordering that order set. And that has to be done before you can move further. On the right side is the inpatient navigator. This is what needs to be done every shift for every patient. In the ED, they may see something like this. It's a navigator to screen for sepsis, and it's also an indicator that we might flag you to say the patient is meeting those criteria for sepsis, and then something needs to be done. So let's test your knowledge. You have a 91-year-old patient, Jim, admitted to your unit several hours ago with the following parameters. Blood pressure is 92/88. Heart rate is 142, sinus tach. Respiratory rate 24. Temp is 100.9 Fahrenheit. White blood cell count 17,000. And Glasgow Coma scale is 12. During your initial assessment, he reports that he saw his family doctor 2 weeks ago and was being treated for a kidney infection. He reports difficulty urinating. Jim most likely is suffering from, is it A, sepsis, B, septic shock, C, or multiple organ dysfunction, or D, late sepsis? The answer is A, sepsis. You see that the patient has a couple of values here in their vitals and their lab results that indicate the Glasgow Coma scale is less than 13. Blood pressure is dipping pretty low. Heart rate definitely is above 90. Respiratory rate is above 20, and temp is high. So the patient indicates that they have those vitals that are unstable, plus a known suspected infection, which the answer is sepsis. So in the hospital, we have a system that alerts care providers. So once it's recognized that the patient is septic, we immediately want to notify rapid response team or the physician. What we do is we get a sepsis alert generated from Epic. We would alert our code team, and the sepsis should be like a code. It should be an emergent situation, because early identification, early treatment decreases the risk for death. So we want to dial 222, and we indicate that it's for code sepsis. RRT will arrive to the bedside, and they will initiate the sepsis bundle. This is the implications of the new definitions for screening and management of sepsis. Step one is for hospitals should continue to use signs and symptoms of infection to promote early identification of patients with suspected or confirmed infection. Of the patients identified as having an infection, management should begin by obtaining blood and other cultures as indicated, administering antibiotics, and simultaneously obtaining laboratory results to evaluate for infection-related organ dysfunction. Step two is screening for organ dysfunction. Same criteria, including lactic levels greater than 2, also can be identified using the quick sequential organ failure, which is, or QSOFA. And the elements in that is the mental status changes, respiratory rate of 22 or above, and systolic blood pressure less than 100. So any of the QSOFA ranges from 0 to 3 points. It's really an indicator of organ dysfunction, not so much screening for sepsis, but it's an indicator. And if those patients that should be identified as the same organ dysfunction criteria, including the lactic acid, if organ dysfunction has been identified, initiate the 1 hour bundle. And we'll go over that in a couple more slides. Step 3 is identification and management of initial hypotension. So patients who have sepsis, including hypotension or a lactic acid level of 4 and above, we should initiate that 6 hour bundle. So these are the goals of the 1 hour bundle. We mentioned this a little bit before in the slides. So once we have the suspicion of or confirmed infection, and they are showing signs of organ dysfunction, we want to initiate this 1 hour bundle. We want to measure the lactic acid. And then we also want to remeasure the lactic acid if it's above 2 or above. So lactic acid is an indicator of hypoperfusion in the vasculature, and that means that the organs are not getting the proper nutrients and oxygen supply it needs. We obtain blood cultures prior to the antibiotics. As those are being sent off, we administer the broad spectrum antibiotics. So we don't know exactly what microorganism we're working with, but we would use a broad spectrum antibiotic, both gram-positive and negative, or depending on what organ is failing, then we can kind of indicate what antibiotics should be used. As in a few days, when those microbiology results come in from the blood cultures, then we would be able to hone down on what antibiotics are needed. We would administer a bolus, so it's a fluid bolus. We would administer 30 mLs per kilogram of crystalloid for hypotension or hyperperfusion, which indicates like through the lactic acid results. If those if the patient's still not perfusing, we would apply vasopressors for hypotension that doesn't respond to the fluid resuscitation. And our goal is to remain a MAP above 65 or above, or a lactic acid, or if the lactic acid's 4 and above. Through that, we would measure the CVP. We would also, that's usually measured through a central venous oxygen saturation, and we measure lactic acid if initial was elevated. So you have a 35-year-old patient, Kendra. She's 3 weeks post appendectomy, who was admitted to her unit last night for rule-out sepsis. During the night, Kendra received 2 liters of fluid and IV antibiotics after blood cultures were collected. Her current morning parameters are as follows: blood pressure 88/48, heart rate 136, respiratory rate 42, it's a high tempo of 102.1. Pulse ox is 88% on 6 liters nasal cannula. White blood cell count is 36,000. Her urine output overnight for the 8 hours is 224 cc's. She appears diaphoretic and clammy. As a nurse, you would classify Kendra's condition as A, sepsis, B, septic shock, C, multiple organ dysfunction, or D, late sepsis. The answer is septic shock, B. Septic shock would include sepsis-induced hypotension despite adequate fluid resuscitation, with the presence of perfusion abnormalities as evidenced by lactic acid, polyuria, and acute mental status changes. This is just a review of the 1 hour bundle again that we would induce for a patient who has septic. So the higher risk of death for patients on the med-surg floors has been attributed to delays in identifying sepsis or treating sepsis. So it's a nurse's role really to make sure that we do our screening properly, that we call or communicate that the patient is septic to our providers. And early indication that is the key to improve patient outcomes. So those are the things that on the nurse's role, what they need to do is they need to understand and to recognize the signs and symptoms of sepsis. The provider's role is help treating that patient with sepsis. So knowledge of the evidence-based guidelines, initiating orders based on the guidelines, and communication and collaboration with other healthcare team members, acknowledging that sepsis is a medical emergency and the key to positive patient outcomes. So sepsis screening tool and other order sets can be initiated for patients who are septic and then also help expedite treatment plans. Let's test our knowledge again. Which of the following mechanisms contribute to hypotension in septic shock? Is it A, decreased vascular permeability, B, increased afterload, C, peripheral vasodilation, or D, increased cardiac output? The answer is peripheral vasodilation. In general, septic shock is associated with three major pathophysiological effects with the cardiovascular system: vasodilation, maldistribution of blood flow, and myocardial depression. So in septic shock, the absolute intravascular volume may be normal. However, because of the acute vasodilation, relative hypovolemia occurs, in contrast to other shock states that are due primarily to decreased intravascular volume, hypovolemia, or decreased cardiac output, which is cardiogenic. A defining characteristic of septic shock is the maldistribution of blood flow in the microvascular system. Additional myocardial depression occurs. The relative hypovolemia, myocardial depression, and maldistribution result in increased oxygen delivery to tissue. Another question: a 7-year-old female arrived to her unit from the ED. The patient was admitted for 1 week of persistent fatigue, change in mental status, diarrhea, and vomiting. Past medical history includes diabetes type 2 and heart disease. Cultures of the urine and lactic acid were sent, and broad spectrum antibiotics were administered. The following parameters are blood pressure 80/52, heart rate 126 tachycardia, respiratory rate 34, temp 98.7, pulse ox is 95% on room air, hemoglobin is 7, white blood cell count 17,000, BUN is 20, creatinine is 2.85, and lactic acid is 6. As an astute nurse, your immediate treatment would include vasopressor therapy, blood transfusion, IV fluid resuscitation, or corticosteroids. So the answer is IV fluid resuscitation. Most appropriate immediate intervention required at this time. Patients that are hemodynamically compromised with hypotension and tachycardia. Given his history of nausea, vomiting, diarrhea, the patient is likely to be very hypovolemic.
Our daughter Erin was 23. She had just graduated from the University of Georgia. She was going on to graduate school, University of South Florida. She went in for a simple hemorrhoidectomy on a Thursday. 5 days later, she was gone to something I had never heard of.
Many death certificates list the cause of death as cancer. Many of those patients die of sepsis. Many death certificates list the cause of death as complications of heart disease, and the cause of death is sepsis. Many death certificates list the cause of death as complications of pneumonia, and the cause of death is sepsis.
According to a recent poll, close to half of all Americans have never heard the word sepsis.
And in fact, I practiced dentistry for 25 years, and I didn't know anything about sepsis.
We have more than 1.6 million cases of sepsis annually in this country. And of those cases, nearly 20% wind up dying.
There's an epidemic that is occurring in sepsis. This has been increasing in the number of cases by about 9% per year. Certain groups of people seem to be at higher risk for sepsis. That includes people like the very young, elderly people, people with chronic conditions like cancer or liver disease. People who are over the age of 65 are 11 times more likely to have a hospitalization associated with sepsis than someone who's less than 65. But there should be no mistake. Sepsis is an equal opportunity killer. It kills the young, it kills the old, it kills the sick, it kills the healthy. Sepsis is really a toxic response to an infection. So your body is constantly inundated with challenges by microorganisms, bacteria, viruses, fungi. And you have an extensive system in your body to try and keep that bacteria from becoming an infection. The problem is that body can also go haywire. And so as a result, instead of protecting you, your body actually starts trying to kill you.
The immune system is mobilized to action like an army, and the white blood cells are firing bullets at the bacteria or at the invaders. And that's fine when the bullets are targeting the bacteria, but it becomes a real problem when the bullets start flying everywhere and you get collateral damage on the patient's own organs. And this becomes a catastrophe.
So you may hear a number of terms that are used in the hospital around sepsis. There's sepsis, severe sepsis, septic shock. Sepsis is at its basic heart this notion of having systemic inflammation due to an infection.
In some instances, sepsis progresses to the point that people's organs fail. When your organs fail or aren't working correctly, this is called severe sepsis. The most serious form of sepsis is when your blood pressure drops as a result. This we call septic shock.
Aaron went in on Thursday for elective surgery, hemorrhoidectomy, just a routine surgery. I'd had it done before. And on Friday, they dismissed her for the weekend. Well, everything seemed okay until Sunday night, and all of a sudden it had a turn for the worse, and the pain level went up. Well, that's completely contrary to a healing phase. So my wife took her back to the hospital. They kept her Sunday night. I went in Monday to see what's going on, and I could tell something was wrong. I mean, I could see her blood pressure was off, very low. Her heart rate was up. I said, "Where's the doctor?" He said, "Well, he's down there." I said, "Well, go get him." And he walked in, he said, "I think she's septic." It's the first time I heard the word septic. She had the infection when she came home on Friday night, but they did not give antibiotics because they told her they were concerned it would cause diarrhea. So if she would have had the code sepsis that we referred to, that is fluids and antibiotics on a Friday night, this was all preventable. And it's such a shock for that to occur and someone die from something you've never heard of. And that changed my life. I was with Erin when she died. She looked at me and said, with her eyes, "Can't you do something, Dad?"
If doctors treated sepsis as a medical emergency in all instances, as many as 50% of deaths occurring now wouldn't happen. And so that's 125,000 people surviving every year who would have otherwise died.
We think that one of the ways to emphasize the need for treating sepsis like a medical emergency is to refer to this in the same way that we refer to other medical emergencies, which is as a code. If you're in a hospital, you might hear a code blue. That means that there's a team that responds to someone whose heart is stopped. We're trying to promote the notion of a code sepsis. And what code sepsis is, take this disease seriously. Suspect it, administer early antibiotics, administer fluids, and get the help you need to provide the care for the patient. Reducing mortality in sepsis is as easy as getting antibiotics into patients. What we also know is that your mortality goes up by about 8% for every hour that passes without antibiotics. Unfortunately, there's not a single sign or symptom that really tells you have sepsis.
But I think there are some warning signs that people can look out for. These can include things like problems breathing, a fast heart rate, either a high temperature or chills, feeling dizzy or lightheaded, particularly when you stand up, and problems with changes in the level of consciousness. And this can include either confusion or possibly being difficult to arouse.
If you're concerned about sepsis, one of the things to do is when you talk to your doctor, say, I'm worried about sepsis. That cues the doctor to think about this as a problem and do further testing.
The first time I felt the sore throat coming on, it was a Friday night. It was just like a slight soreness in my throat, nothing major. The next morning I woke up and it was the worst sore throat of my life. I actually could barely talk. I was having trouble breathing. I started running a really high temperature. I started throwing up blood. That's when I realized it was time to go to the emergency department.
And at that time, the thought was that she probably just had a viral illness like a cold leading to a sore throat. Over the next couple days, however, she got worse. Had increasing confusion, noticed her skin was mottled or had a blue discoloration, and wound up coming to the hospital a second time.
When I was admitted to the ER, they reported that I was already in septic shock. I had H1N1. I was in renal failure.
In Jen's case, her sepsis led to the formation of small blood clots in small blood vessels throughout her body. As a result of that, she didn't get enough blood flow to her extremities, and that led to gangrene, which is tissue dying.
And I do remember looking at my hands and seeing that they were black and they were curled into like a claw because they had died, but not understanding what that meant. And also seeing my feet and toes and they were black.
As a result of that, she required amputations.
I remember my mom coming into my room and saying, "It's time for you to go to your surgery." And I just started crying because I felt like I wasn't going to make it through the surgery. And there was so much I wanted to tell my mom, but I couldn't talk at the time. So I just said, "I'm sorry."
It's hard to really understand how sick she was. Her family was called in multiple times to her bedside because the doctors all thought she was going to die within minutes. And she was as close to death as anyone can be.
It was extremely touch and go for months.
She just slowly started getting better, but it still took her months to recover. The great unknown is the number of people who survive sepsis but are significantly disabled as a result. And those disabilities can be obvious, things like amputations, but they also can be things that are hidden, like problems with thinking, memory, calculations. Some even suffer from post-traumatic stress disorder. We feel happy that they've survived, but they're still carrying the scars around with them for the rest of their lives.
Well, I want to share my story because I've always wanted to help people, and I think this is a good way. I've always had that drive, but now it's in me even more. It makes me feel good if just one person knows what sepsis can do and how important it is to get treatment for it immediately so that there aren't grave consequences.
And it all comes down to hope. That is, hope from shared responsibility that an informed public can work with their healthcare providers to reduce the deaths and disability from sepsis. The public will have to be empowered to demand and ask for early treatment. They must show that they're concerned about it, and you always have to have an advocate with you, checking everything that's done.
It is possible to improve the treatment and the survival from sepsis in the future. Will we be able to prevent any patient with sepsis from dying? Probably not. But will we be able someday to significantly improve the mortality rate of severe sepsis? Absolutely yes. But we're not there yet. We have a ways to go.
However, this is a disease we could affect today. We don't need new scientific discoveries to reduce the mortality rate by 50%, to cut the number of people dying in half. All this takes is us doing a better job.